So you may ask yourself, what the hell are those? You'll be learning what it does later on. Now, there are particularly two types of calcium channel blockers. One of which is non-dihydropyridine calcium channel blockers, which are your diltiazem and verapamil. And another would be the dihydropyridine calcium channel blockers, which are your nicardipine, amlodipine, nifedipine, nimodipine, and clevedipine. You may remember your dihydropyridine calcium channel blockers through the suffix "pine" or "ine," for instance. It's very important for you to remember these because it'll help you classify the different types of calcium channel blockers. Now, essentially, the mechanism of action for non-dihydropyridines usually works on the heart in this case. So, action potentials propagates across the sarcolemma and travels downwards the T tubules, which triggers the sarcoplasmic reticulum, which in turn releases calcium. It then opens up voltage sensitive dihydropyridine receptors and calcium L-type channels to allow the influx of calcium into the cell. Now, when this happens, it travels towards the myosin and activates it, ultimately causing a cardiac muscle contraction. So the sarcoplasmic reticulum particularly stores calcium. So when it is activated, calcium will be released out of the sarcoplasmic reticulum, which then increase the free flow in calcium, which in turn causes a muscle contraction. Now, the entrance of calcium inside of the cell is called the phase 2 phase, shown on the left. On the phase 3 phase, this is basically what causes the rapid repolarization of the triggered cell, and which the calcium channels close to prepare for phase 4, which is the resting potential. Now, as what I said earlier, particularly calcium channel blockers inhibit the L-type calcium channels, both found on the pacemaker and contractile cells on the heart. So now this leads to decreased action potential, therefore decreased influx of calcium inside of the cell, and therefore decreased muscle contraction. You can see that diltiazem, it blocks the inhibition of calcium, which then decrease calcium influx and essentially decrease contractility of cardiac myocytes. Now, the mechanism of action for dihydropyridines, which are a different type of calcium channel blockers, is what I said earlier. You can see the mechanism of action on the right side. Essentially, calcium enters the cell, the sarcoplasmic reticulum releases calcium and an enzyme called calmodulin combines together, and when this happens, it essentially causes the inactive form of myosin light chain kinase to become active. And when myosin light chain kinase is phosphorylated, it causes a muscle contraction, shown on the right here. Now, just so you know, dihydropyridine, unlike non-dihydropyridine calcium channel blockers, works both on the heart and the vascular smooth muscle. So essentially, it's basically the same. It basically blocks calcium from entering the L-type calcium channels, which decreases action potential and ultimately causes vasodilation on the peripheral blood vessels. What are they used for? So here are the indications. You may want to use calcium channel blockers for hypertensive crisis, Prince-Metal angina, stable anginas, atrial fibrillation and atrial flutter, and symptomatic premature contractions. Now, usually we wouldn't give patients calcium channel blockers if they are asymptomatic with premature atrial contractions, but if they do show up symptomatic, you may want to give calcium channel blockers to help. Now, contraindications. Obviously, you wouldn't want to give calcium channel blockers to patients with acute myocardial infarction, pulmonary congestion, vasodilation in the peripheries. It increases capillary fluid, therefore likely tendency for fluids to actually leak out of the blood vessel, therefore causes peripheral edema, which worsens the pulmonary congestion. You wouldn't want to give patients with hypertension or bradycardia, because essentially it slows down the heart rate even more. So here's some adverse effects, both from non-dihydropyridine and dihydropyridine calcium channel blockers. So obviously it can cause hypotension, considering it decreases the heart rate, and essentially what it does is lower the blood pressure. What it can also do is actually a thing called reflex tachycardia. When there is vasodilation in the peripheries, this decreases blood pressure, right? Now, when this happens, it actually activates the carotid and aortic sinus. So when this happens, this increases the activity of sympathetic nervous system, which then increases the heart rate, therefore reflex tachycardia. Now, this can also lead to peripheral edema, like pedal edema or calf edema. This can also lead to syncope, because when there's a decrease in heart rate, this increases the risk for heart block. And when that happens, there is a decreased flow of oxygen to the brain, and therefore leads to syncope. Now, another interesting thing about calcium channel blockers is that, particularly amlodipine, it can actually lead to gingival thickening, which is essentially gingival hyperplasia. Thank you for watching this video, and if you will, kind enough, please be sure to support me, like the video and subscribe. And if you want any more videos like this, be sure to comment it, and I'll be sure to reply to it when I can. Thank you.